Hello, dear students. I am Dr. Kiran Mahendru, Assistant Professor from DMCH Ludhiana, and today I'll be talking about neuromuscular monitoring. So I'll cover this topic under the following outline. Firstly, we'll discuss briefly about the physiology of neuromuscular junction, the rationale for monitoring neuromuscular blocks, the complications and consequences of any residual neuromuscular blockade, what are the indications for neuromuscular monitoring, the principles of nerve stimulation, differential muscle sensitivity to these neuromuscular blockers and what are their clinical implications, the various sites used for stimulation, stimulation patterns, methods of neuromuscular monitoring, clinical practice strategy, and the ASA 2023 guidelines. So coming to the basic physiology of the neuromuscular junction, we know that the motor neuron comes from the ventral horn of the spinal cord, where it gives various branches, which will then innervate multiple muscle fibers. This motor neuron, along with the muscle fibers that it innervates, form a motor unit. Now, a neuromuscular junction is basically formed by a distal nerve terminal, the Schwann cells which cover the distal nerve terminal, the synaptic cleft, and the muscular end plate. Now, as you can see in this diagram, so there in the nerve terminal, you can see some active zone or the release site, which contains the neurotransmitter, which is the acetylcholine in these vesicles. Then there is a synaptic cleft present between the nerve terminal and the muscle end plate. The muscular end plate basically is formed by various clefts. These are the primary and the secondary clefts. Now, these clefts, they contain the sodium channels, voltage-gated sodium channels. And on the shoulders of this muscular end plate, these black dots, these are the acetylcholine receptors, nicotinic acetylcholine receptors, which respond to the acetylcholine release from the nerve terminal, which will then lead to the muscle contraction by its action on the actin-myosin complex. So here you can see that the sodium channels are present in the primary and secondary clefts, and they are also present in this perijunctional region, which will understand during the process of accommodation. Now, basically, neuromuscular transmission, it is dependent on the release of acetylcholine, which is released from the prejunctional nerve terminals from the vesicles present from the release sites. Now, this acetylcholine, when released, it binds to the acetylcholine receptors, which are present prejunctionally as well as postjunctionally within the neuromuscular junction or the synapse. Now, there are two types of acetylcholine receptors. One are the muscular subtype, and the other variety is the neuronal subtype of acetylcholine receptors. Now, the muscle relaxants which we give during anesthesia, they have either an agonistic or an antagonistic action on these post-junctional nicotinic acetylcholine receptors. The agonistic actions is via the depolarizing muscle relaxants, which includes choline, and the antagonistic action is via the non-depolarizing muscle relaxants like vecuronium, rocuronium, etracurium, etc. Now, non-depolarizing muscle relaxants, what they do is they prevent the excess of acetylcholine to its preferred recognition site. That is, there is a competitive antagonism by these muscle relaxants on the post-junctional nicotinic acetylcholine receptors. Therefore, this neuromuscular junction is basically a very complex and dynamic system, and the phenomena which is produced by the various drugs which we use will be a composite of actions which will vary on the type of drug which we are using, the dose which we are giving, the activity at the nerve terminal and the muscle end, the time after administration of the drug, presence of other drugs in the body, and the age and condition of the patient. Now, some description of the Quantal theory for neuromuscular junction. Now, when we observe the electrophysiology of a skeletal muscle, we will see that there are small spontaneous depolarizing potentials seen at the neuromuscular junction. These small spontaneous depolarizing potentials, which are seen normally, are known as miniature end plate potentials. They have 100th the amplitude of an evoked end plate potential, which is produced when we stimulate a motor nerve. Now, apart from the difference in the amplitude, these miniature end plate potentials, they resemble the end plate potential in time course and manner in which they are affected by the drugs. So basically, it is a unitary response which is seen at a neuromuscular junction, and size of all these miniature end plate potentials is either equal to or multiple of this minimum size. So basically these miniature end plate potentials, they are produced by uniformly sized packages or what we call quanta of transmitter, which is released from the nerve in the absence of stimulation. Now, when we apply a stimulus to a motor nerve, the stimulus evoked end plate potential will be the additive depolarization, which is produced by synchronous discharge of quanta from several hundred vesicles. So when we stimulate a motor nerve, there will be discharge of various quanta, a multiple of quanta to cause muscle contraction. The amount of acetylcholine which is released by each nerve impulse is large. What happens? It leads to sodium and calcium ion flow through the channels of the activated acetylcholine receptors and cause maximum depolarization of the end plate. This end plate potential is usually greater than the threshold which is required for the stimulation of the muscle fiber. Therefore, approximately 200 quanta of approximately 5,000 molecules each is released with each stimulus, and the total number of acetylcholine receptors which are activated by the nerve impulses around 500,000 molecules. What this shows is, as per the Quantal theory, we know now that the system is extremely vigorous. As you can see in the neuromuscular junction, you have already seen the diagram. The release sites of the acetylcholine vesicles is located immediately opposite the receptors present on the post-junctional surface. Little transmitter is wasted, and the response of the muscle is coupled with the signal from the nerve. The signal is carried by more number of molecules of transmitter than it is needed for the response to be elicited. And the evoked response is also larger than needed. And only a small fraction of vesicles and receptors are utilized for a particular response. So what all this means is that we have a substantial margin of safety when it comes to the neuromuscular junction, as the signal is carried by more molecules than needed, and the evoked response is also larger than needed. And also, there is substantial capacity in the reserve for the neuromuscular junction, because only a small fraction of the available vesicles and receptors are used for the muscle contraction. Now, we should know the basic structure of the acetylcholine receptors, nicotinic acetylcholine receptors. Basically, it consists of 5 pentameric structure which forms a cylinder, and there is a central cation channel present. So there are immature receptors, mature receptors, and some neuronal receptors, acetylcholine receptors present in the muscle. So talking about the immature receptors, they are present in the fetus and they are converted to the mature receptors by around 2 years of age. Immature receptors, they consist of 2 alpha subunits, 1 beta, delta, and gamma. Basically, they are low amplitude receptors, but they remain open for a longer duration of time. Coming to the high conductance or the mature receptors, which are seen in the adults, basically, it consists of 2 alpha units, beta, delta, and epsilon unit, forming a pentamer with a central cation channel. And these are high conductance channels. That means they produce a high amplitude response, but they remain open for a shorter duration of time. Now, coming to the basic structure of the acetylcholine receptor, this is the nicotinic acetylcholine receptor with the 5 subunits and the central cation channel seen. Now, basically what happens is when acetylcholine is released from the nerve terminal, the acetylcholine molecule will go and attach to the 2 alpha subunits of the acetylcholine receptor. Now, for the channel to